HFrEF starts at the heart and then goes elsewhere, but HFpEF starts elsewhere, everywhere, and ends at the heart. So basically, HFpEF patients are more sicker patients. Generally, preserved ejection fraction means ejection fraction more than 50%. And generally, such patients are females, obese, diabetics, hypertensives, atrial fibrillation, and maybe COPD also. And there is a lot of metabolic stress, aging, cardiac remodeling, vascular stiffening, sedentary lifestyle. Eventually, that leads to heart failure. That is heart failure with preserved ejection fraction. There are a lot of studies which have failed in HFpEF patients, like the CHAMP-PRESERVE study, CHAMP-PRESERVE with candesartan, I-PRESERVE study with irbesartan, PEF-CHF study with perindopril, TOPCAT study with spironolactone. Even DIG trial did not show any benefits. There were a lot of failed trials in HFpEF. And clinical outcomes, if you look at HFpEF and HFrEF in the various observation studies, they were actually similar. The patients have similar symptoms. So there were a few trials like PARAMOUNT trial, which showed improvement in the soft domains with the ARNI, like improvement in the NT-proBNP levels, improvement in LA size, improvement in NYHA class also was seen. PARAGON heart failure trial also was a randomized double control trial which compared valsartan with ARNI. And if you look, the composite of total first and recurrent heart failure hospitalization cardiovascular deaths were seen, and they were definitely better. And there were a lot of improvement in the NYHA class of the patients, and KCCQ questionnaire, cardiomyopathy questionnaire was there. And also worsening renal function and all-cause mortality, they were better in the PARAGON heart failure trial. See, you can see heart failure hospitalization and cardiovascular deaths. Although deaths were not very, very significant difference, but definitely significant difference between the heart failure hospitalizations. You can see there was some difference, heterogeneity was seen in this PARAGON-HF trial. Like the males did not benefit that much, the females they benefit more. So as I've mentioned, the females generally have HFpEF more commonly, and males generally have HFrEF more commonly. And ejection fraction at a cutoff of 57% was found. That if ejection fraction, if it was more than 57%, there was no major benefit seen. But up till 57% of ejection fraction, there were definite benefits which were seen. And as I've mentioned, HFpEF is hardly ejection fraction more than 50%. So I think that 40 to 50% area, definitely they benefited. And these benefits, the primary composite of endpoint and various parameters, if they compared, they were all seen. Lesser the ejection fraction, more the benefit. But once the 57% cutoff was seen, then the ejection fraction, if it went up more than 57%, the benefits are not seen in the PARAGON-HF trial. Yes, so the EF cutoff for the benefit was 57%, which is as good as normal only. Now, Butler et al. Had compared various patients. They are divided such patients with HFrEF to maybe HFpEF into various categories, right? From ejection fraction less than 25% to 25 to 30, 35, 35 to 40, and so on, 50 to 60, and more than 60. And what he could find was that lesser the ejection fraction, more the mortality and morbidity and heart failure hospitalization benefit in patients.